Okay, we'll now move on to the next presentation, which is a review of the adult registry, which Dr. Chen has taken over from Vicky, who looked after it until last year. So Fred's going to summarize where we are with the registry.
Right, so the UK Adult ITP Registry was launched about 20 years ago. And I just want to emphasize this registry is a research project, and it's governed by research ethics of the United Kingdom. Now, the reason for collecting patient data for research is because ITP is a poorly understood condition. It's diagnosed by excluding other causes of platelets. There's no diagnostic test for ITP. And it is not possible to predict the severity and prognosis of the disease, and it's not possible to predict a response to treatment and what is the best drug to use. And this is the reason why we're collecting the data in order to find out, to address these questions. Now, in the formal ethics approval for the application for this registry, there are two study objectives. The primary objective, which is study the aspects of the diagnosis and biology of the ITP, try to understand the ITP. And the secondary objective is to analyze the outcome and safety of new treatments, which is getting increasingly important because of the new introduction, of many new drugs. So the UK Adult ITP Registry now has over 5,000 patients. And there are three branches to this ITP registry. The first one is the largest one for adult primary ITP. And then there's another one, so that's a primary. This here, you see the sort of biggest 25 recruiting centers to the ITP registry. And this is the new registry, which was set up a year ago for secondary ITP. And this is the top recruiters to the pregnancy ITP that Vicky has just described. So this is a map of the ITP recruiting centers. I mean, when this registry started 20 years ago, most of the patients were recruited from the London region, but now this is extended to most regions of the United Kingdom. And the other thing I wanted to mention is that the recruitment of patients for the registry is facilitated by a network of NIHR clinical trial practitioners and nurses. And this is a government-funded organization that promotes clinical trials in all parts of the country. This really just shows you the annual recruitment rate to the registry. And you can see for the past 10 years, the recruitment has been pretty good and stable, even through the COVID years. So what can we do with the registry? So recently we've looked at the registry data and tried to chart the changes in the treatment that has happened over the last 20, 30 years. Now, this is just a cartoon showing the history of ITP treatments. I think David Cooter has already given a more detailed version of this earlier this morning, but I think what's important to emphasize is we had kind of three eras in ITP treatment. The first era started in 1916 with splenectomy, and the splenectomy has remained the mainstay of treatment for most of the century up to around 2000, when rituximab was introduced. And then this is one era, and then the third era started with the introduction of the TPOs around 2008, initially with ribostim, and then eltrombopag, and then avatrombopag. And around the same time, we had fostamatinib, mycophenolate came into the therapeutic pathway around the same time as rituximab. And this has been sort of quite popular in the United Kingdom. And of course, there are lots of new drugs that are waiting to come into clinical practice. These are being currently trialed in various teaching centers. So we looked at the change in how we use second-line treatment. So these are basically non-corticosteroid second therapy drugs. And we can see that, if you go back 10 years to the last century, splenectomy was the main treatment for ITP, well over 60% of patients. And you can see that how splenectomy has completely disappeared. Yeah. In fact, now in the last 5 years, since 2019, we now have a TPOs dominating second-line treatment after steroids and IVIG. MMF is still popular in the UK, and rituximab has also been squeezed out of the treatment pathway. I mean, rituximab came in early 2000 in the treatment of ITP, and expanded and covered around 30% of patients in the 2000s. But in the last 5 years, it's only a very small proportion of patients, around 8%, who get rituximab. So we then looked at the number of lines of treatments that patients have. And, we went to the registry and we just looked at the patient in the last era, which is the last 5 years from 2019. And this period is quite interesting because this period reflects the new guidelines, but it also happened during the COVID era. So there's an influence by the guidelines and by the pandemic. So we had around 800 patients, precisely 864 patients. And it's interesting that 17.6% of patients did not require any treatment. 82.4% did require treatment. They require first-line treatment, which is mostly with steroids and IVIG. But you can also see that 9% of patients received TPOs upfront. And this is because during the COVID pandemic, the NHS issued a directive allowing us to use TPOs upfront in order to minimize immunosuppression to protect patients from COVID. And so if you look at, go back to the original number of patients, of the 712 who required first-line treatment, 46% went on to second-line treatment, and mostly consisting of TPOs. 12% required third-line treatment, and 2.4% required fourth-line treatment. According to the guidelines, I think first-line and second-line treatment pathways are quite clear-cut. First-line with steroids and IVIG, and second-line with TPOs or rituximab. But I think there's still unclarity regarding the best treatment for third-line and fourth-line treatment of ITP. So there's an unmet need for both data and for guidelines for this group of patients. There are lots of therapies for third and fourth-line treatments. You have all these new drugs. The only one that's licensed so far for third-line treatment is fostamatinib. So this is for patients who have failed TPOs. And there are also lots of waiting drugs still undergoing clinical trials that have not come onto the market yet. And then there are lots of old therapies. And, we know a lot about rituximab, azathioprine, mycophenolate. But we just did a survey to look at the utility of this interesting drug called dapsone. And again, we looked at the outcome of splenectomy, not in context of first-line treatment or efficacy of these drugs in first-line treatment, but do they have a role to play as a third or fourth-line treatment? So I just show some data that were extracted from the registry on splenectomy. So the other thing I wanted to mention is that recently there have been a few publications suggesting that splenectomy remains an effective treatment, even late in the therapeutic pathway. So, some of these papers suggest that splenectomy is very useful, even if you use it as a third or fourth-line treatment. Now, we split our data. So these are all the patients who have splenectomy, and we split them according to the era, which I defined earlier on. So these are the patients with splenectomy up to 1998, from 1954 to 1998. The green line represents patients who had splenectomy between 2000 and 2010, which is the era of rituximab and MMF. And the third line represents patients who had splenectomy after 2011. In other words, the era of the TPOs. This is a so-called Kaplan-Meier curve, and it basically tells you the survival. In this particular case, it tells you the rate of loss of response to treatment. So you can see that patient who had splenectomy back in the from 1950s to 2000 had very good response after splenectomy. But if you look at patient with splenectomy later on, after 2000 and after 2011, then the outcome is actually very poor. Now, what is interesting, if you analyze these groups of patients, you'll find that the early cohort of patients use splenectomy as an upfront treatment or second-line treatment, whereas the two other groups of patients, splenectomy was used much later on as third-line or fourth or fifth-line treatment. So we then went back to the data and divide the patient with splenectomy into two groups, those who had up to 2 splenectomies before, so up to 2 lines of treatment before splenectomy, and those who had splenectomy after 3 lines in treatment. And clearly, those who had up to 2 prior treatments before splenectomy had a better outcome compared to those who had more than 3 lines of treatment before splenectomy. And in fact, those who had more than 3 lines of treatment before splenectomy, the outcome was the median response to splenectomy was only 3 months. Whereas those patients who had up to 2 lines of treatment before splenectomy had a median response of 20.8 months. And there's also a difference between those who are greater than 65 years of age and those less than 65. So if you're older than 65, the outcome of splenectomy is much poorer than if you were younger than 65. So splenectomy seems to have achieved good response when used early as first or second line therapy. There you have a median response of 20 months. But the outcome is very poor when you use it as a third line or beyond. And there the median response is about 3 months only. So the question is whether it's worth doing the splenectomy. Splenectomy outcome is poor in patients older than 65 years of age. Now, current guidelines recommend splenectomy as a last resort treatment after at least 24 to 48 months of pharmacological treatment. But then the probability of sustainable remission in this setting after 48 months is extremely low, as I've just shown. Although this does not exclude the use of splenectomy in these patients, I think careful case selection is really critical. And one way of selecting may be to use Indian platelet sequestration scans prior to splenectomy to predict whether you're likely or how likely you are to respond to splenectomy. The other drug that I wanted to mention is dapsone. This is a really curious drug. It was developed in the 1930s. It's kind of a sulfur-based drug, and it was actually first developed as kind of an antibacterial treatment. But currently, the label indication with dapsone is for leprosy and for dermatitis herpetiformis. And it's also used as prophylaxis against a type of pneumonia called PCP for those patients who are allergic to cotrimoxazole or Septrin. So we looked at the patients in the registry who received dapsone. We found 30 evaluable cases in the registry, and these are the outcomes of ITP to the use of dapsone. So the overall response is about 50%. By overall response, I mean maintaining a platelet count above 30, which in most cases is sufficient for good health. The complete response rate is about 17%. This is quite low, but actually it's not that much different from some of the very expensive modern drugs. What we also found is that the number of lines of treatment that had prior to dapsone is 3, 0 to 12, with a median of 3 for responders. So actually, this drug, although the results are not very good, it actually works late in the therapeutic pathway. So you can use it in patient who has been resistant to TPOs or some other third-line treatment. So again, this is a couple of my curve, we're showing the loss of response to dapsone. And you can see that the median time of dapsone, which is more or less equivalent to how long dapsone patient respond to dapsone, is around 147 days, which is between 5 to 6 months. And there are a few patients who have sustained responses and who even have treatment-free responses. So they remain in remission or remain with a good platelet count after stopping the dapsone. So in summary, this is how dapsone was used according to our registry data. Well, first of all, just repeating what I said, 50% overall response, 17% complete response, median duration of response is 5.3 months. It works in multi-resistant patients who had at least 3 lines of treatment, and there's been no evidence of anemia or other toxicity. One complication with dapsone causes is hemolysis or a drop in hemoglobin, but we haven't actually seen that in our registry data. But dose use is 100 milligrams once daily. We should wait for at least 4 weeks before we can say whether the drug works or not. And as I said previously, it's a cost-effective drug. So these are 2 examples of the power of the registry. There are many challenges in ITP, and some of these challenges could be addressed with the registry. There are many new emerging drugs which are still undergoing clinical trials. There's an unclear positioning or sequencing of these new and old drugs in the therapeutic pathway. But obviously, currently, the research appears to be focused on these 12% of patients who require third-line treatment, and there are a lot of drugs competing with these 13%. And then, what is the role of combination therapy? And then, of course, the most difficult problem with the diagnosis of ITP is there's still no diagnostic marker of ITP, nor is there a predictive biomarker for disease stratification. So these are all the challenges that we hope we'll be able to address with the registry. So looking forward, I would say with optimism that we have now a critical mass of 5,000 patients, and this will enable us to produce quality analysis. Hopefully, or at least we aim to identify predictive markers for disease stratification, perhaps by analyzing how different patients respond to the different drugs. And in a kind of reverse stratification, we may be able to find some biomarkers. And then we're quite keen to develop artificial intelligence. Now, just a few more slides. So we have been exploring the possibility of using artificial intelligence, or so-called machine learning. And essentially, this is how it works. You have, a machine, a computer here with a machine learning program. And you input data from laboratory results, demographics, and hopefully in future from genetic results into your program. And then you can come out with newly identified biomarkers for stratification of ITP into subtypes. So this is what happens. So basically, you have different types. ITP is heterogeneous. So you have different types of ITP, and hopefully you can divide your population into different groups, can then end up with different treatments. So you can individualize or personalize a treatment. And we have taken steps to do some preliminary studies. Oh, sorry, I've missed that. I missed that. But we did some preliminary studies with artificial intelligence, and we have found a few off-the-shelf programs able to predict between ITP and non-ITP patients. I mean, this is very basic stuff, and by at least we have found the machine learning is able to differentiate between ITP and non-ITP. Ideally, what we want to do is to develop a program, a machine learning model, they call it, that is specific for ITP. And so this is the kind of a vision for the next 5 to 10 years. Thank you.